Hello, good afternoon, everyone. Um, okay, so our today's topic is global health security, and we will review a tool, EWARS, which is widely deployed in during emergencies. But first, what we will do is we'll build a foundation knowledge on what is global health, and then we will gradually learn on what is global health security and what is global health agenda. So my name is Arif Bukhari, and I'm working for WHE, HIM, Health Information Management at AFRO. And uh, let's begin with the agenda. So we will first review global health and global health security agenda, and then I will give you overview of how WHE is working in, during the emergencies to manage data, and Health Information Management Program is leading the data management pillar during the emergencies. Then we will go and review digital health and the importance of digital health in the context of emergencies and in the context of active surveillance throughout the region. Then we will review the challenges and solution and the approach that WHE is taking up to resolve these issues. And then we'll begin with digital health tools. I will show you like how many tools are available and who you can coordinate with at the regional level to assist you to develop or deploy the tools in the emergencies. And then we will have a little bit more overview on EWARS in a box. It will be little detailed, but not cover the implementation part because it's too technical, and we already planned a training for that implementation part. So it will, you will receive the training information soon. It is planned for the countries in 2019. Okay, so let me begin with the first one first. So what is global health security? And to understand the global health security, we need to understand global health. The objective of global health security is to improve the health of individuals, regardless where these people are. In Gambia, in Nigeria, Afghanistan, Pakistan, or whatsoever. How we reach to global health security is the world is starting to realize after the spread of HIV throughout the world and SARS and bird flu, when people, they were scared about how do we, if we get chicken and we eat chicken, we might get bird flu and avian influenza. And then in 2014, West Africa Ebola outbreak, which brought attention to global health as a whole, and world started to realize like what we need to do now is we have to make collective effort in order to contain the outbreak, in order to minimize the effect of the outbreaks on human lives. So, but for now we will review like what exactly is global health, what it covers, and what are the underlying causes of global health. So to begin with, we have to first define what it covers as a whole. So the widely accepted definition of global health is with justice and human rights as its foundation. Global health is an area of study and research and practice that places a priority on improving health of individuals worldwide, as I defined earlier. Global health security. Now we are living in a global village. There are thousands of flights every day from Lesotho to Brazzaville to France to you name it just. So the expectancy of the disease spread is very high. So all population is likely to be at a risk. And we have seen this in 2014 that when one case flew from from West Africa to the US, and it made a serious crisis to contain this outbreak. What else global health covers? It's just not about the infectious diseases. It's about the culture, the trends, fast food culture. Like if you're eating too much fast food, how it will impact on your health, and diabetes, heart diseases, cancer, you name it. Global health always and also stresses on girls' education. I am not aware that if you hear the same saying as I heard, if you educate one girl, it means that you are educating a family. So by educating a girl, you are reducing the rate of mortality. And how you do it? Because you teach them to hygiene level, how to be hygienic, how to produce food hygienic, how to um, be clean, how to make your family clean, how to guide them on separate systems and things like that. So the other stress on poverty, because if you don't have money, then you cannot get better health, you cannot get better housing, you cannot get better food for your family, for yourself. So it covers poverty as a whole, and it covers growing flows of goods, money, technology, knowledge, and many more. And all of them has a wide impact on our health as an individual. So on the capacity building and assistance, global health realizes that individual countries, they do not have this much capacity to fight the outbreaks such as Ebola outbreak. As you have seen, maybe most of you are aware of the ongoing events in DRC. It's a 10th outbreak in DRC, which is kind of very critical one, because you have an outbreak in an area where you have already humanitarian crisis, which is there from almost 10 to 20 years, and how to tackle it. And it's on the surrounding of border area. So how do you make sure that this outbreak do not pass and cross boundary and go to other places? To understand the underlying causes, it also stresses on what are the underlying causes of the issues. So it covers environmental, social, and cultural, economical, and political, and behavioral, and biological, almost all the pillars, which can have a big impact on your health. And it looks for a solution that cross boundaries between different sectors and disciplines. For example, IT sector, we are here today as digital health. We are conducting this workshop. We have different backgrounds. Some people are here from IT industry, some are from health industry, some are from media industry. So it is bringing together all these people and societies to implement the solutions jointly, and you can add as many as you want: engineers, teachers, parents, business communities, politicians, professions working in governments, which is a critical one, civil societies, and the private sectors as well. So what is the thinking behind all this? Global health thinks about entire population. It is not thinking about one specific country or the developed country already or underdevelopment. It is thinking as a whole. And it's also thinks that it's a collective responsibility for health issues regardless where they occur or who is affected. And it seeks for community engagement to work together to stay healthy. And it also seeks for trade agreements, urban planning, migrations. So the migration I already talked about, like if a case passes the border, crosses the border from DRC and goes to Rwanda, and what will be the impact of this outbreak in Rwanda, and how are we prepared to contain that at the point of entry. It also stresses on environment. For example, the recent cholera outbreak in Zimbabwe, cholera outbreak in Tanzania, the sewerage systems, when you have like overflowing rain, how you are going to tackle it. Will it affect the quality of water? Will it affect your community? Will it affect your people, individuals? Then the challenges for an aging population. As you grow old, you have different challenges like arthritis, and you name it. You can just count it on your fingertips. And then it thinks about whose voice counts in global governance. So it's not just whoever you talk will make an impact on global governance. You need to identify those people who will make a difference, who are the decision makers. So what does global health needs in order to do all that? It needs diverse people like you to find lasting solutions. So now I think we understood what is global health and what it covers, what are the underlying causes of global health, and in order to achieve all that, we have global health security agenda. Global health security agenda was launched in February 2014 in the mid of Ebola outbreak, because in West Africa, because then the community realizes that no, we need something to bring all these people together to make collective effort in order to respond to the events and crises and disease outbreak and of infectious diseases. So it's a growing partnership now of over 64 nations and international organizations and non-government stakeholders. The agenda also covers how to build countries' capacity, and it has a detailed information. You can download the Global Health Security Agenda. You can go to the website of Global Health Security, and you can easily get. You will find a lot of information there. And the agenda also covers to elevate global health security as a national and global priority. So in order to achieve global priority, we have to first focus on the national capacity and the national, to improve the national capability and the skills of the people on ground. The approach that Global Health Agenda pursues is multilateral and multi-sectoral approach to strengthen global capacity and the nation's capacity to detect and to prevent and to respond to an outbreak. So that's it for global health security. And now I would like to give you an overview how WHE and HIM is working together in compliance with global health security agenda, and in order to follow all these rules, set of rules, and apply in real world scenario. The functional and strategic focus and modus operandi of the HIM program. So first we have to see like what is the scale of the challenge in the overall region. So recurring outbreaks and complex emergency, like by recurrence I mean you will find that the same cholera outbreak is happening in some particular time again and again in Tanzania, in Zimbabwe, in Cameroon, and other places. And it means that all countries in Africa at risk all the time, not just in Africa, but throughout the world as well. So what we need in order to manage it well, we need better data for better decision making. And I will further show you what challenges we have in order to get the data during the outbreak and after the outbreak and in passive surveillance. So first is if the information you will get the information, the news can travel, ultimately it will reach to you, but when you need it for proper action, it's what we need. If we don't have timely information and timely data sharing, we cannot produce any information, any analytics for top management to make proper and effective decisions efficiently, of course. So HIM program, what we do is the first function that HIM Health Information Management Program covers is surveillance, and we ensure we follow up 47 countries when we regularly monitor them to detect outbreaks. We monitor rumors, we monitor the country's SITREFs, the bulletins on the weekly basis, and we liaise with them every day on the basis of rumors, and then we confirm rumors with the countries, and if they are true, then we begin more investigation. If the rumor is true, then we do risk assessment. What is the risk of this outbreak? What areas we should prepare to contain this outbreak? If it's on the border area, which countries we want to ensure that they get timely information and they take proper measures in order to save their borders, point of entries. And after risk assessment, we give grading to the risk, and then we have one function of data and information management, which collects all this information on evidence-driven decision making, and then we produce reporting, which is annual reports, weekly reports and bulletins, and of course, if you guys are subscribed on the WHO bulletin or on AFRO website, then you will receive the information on the weekly basis on the DRC events, on the ongoing events, on other emergencies in African region. So HIM focus area is about outbreak information as a primary one. So we do event-based surveillance, and we also monitor IDSR threshold analysis. We do threshold analysis on IDSR. We get in touch with the countries. We get data on time. If we get data on time, we can do it much better. We use epidemic intelligence, and then we assess the risk. And for the risk, there are three components that we follow: risk mapping, risk assessment, and risk management. All of this is followed by our DVA team, which is detect, verify, and assess. Then we do data science, and GIS is an important function of HIM focus area. We do automation of whatever information we receive. We monitor the inboxes of AFRO outbreak, and we capture all that data, and we transform it in our ETL tool, and it then saves it to the database, and we then produce real-time analysis from that. We also do humanitarian crisis information management. So most of our bulletins that we produce, information products, you will find always that there is a component of humanitarian crisis, which will give you detailed information on how the countries is managing humanitarian crisis, and if they need support, to what extent they need support, if they need funding to do that, how extent, for example, if they are flood, it means that there is expectancy of having malaria and some respiratory infections. And we produce infographics as well. So organization of health in emergency data and information, we have distributed in proper heads. Like for alerts, we have a separate repository. For contact tracing, we have a separate repository. Surveillance, case management, laboratory, points of entry, vaccination, coordination, and GIS, of course. And then we use all this data to do modeling and predictions. For the prediction part, it's not that well for now, but because of the data, we don't have the qualitative data all the time. And we also connected with the environmental heads, so that you have the proper information on what's going on if there will be a rain in Tanzania, what will be the impact, how it will affect people's life. So the organization of surveillance, we have early warning. Then how do you use this early warning? There are two ways. You can develop on the health structure, which is, by health structures I mean the health facility, hospitals, and the proper administrative structures in the country. And then you have the community level, where you can dig in more towards the individual reporting side. Then we have one pillar of contact tracing and active case finding, data management, documentation, and then you have modeling and prediction. So basically, the data, if you see early warning, the data starts flowing from early warning to contact tracing, then active case finding. Then we have a proper data set that you can utilize to manage and produce reports, information products, bulletins, and then you can do further modeling on and prediction based on these data sets. So it depends. You will always find some different heads during the emergency. So, for example, you have logistics. People, they need water. They don't. You deployed your teams and you in a remote area. Now they need food to survive. They are living in a camp. I can give you a great example on Equator outbreak in Bikoro, and where we deployed our health workers, and they had challenges to get water and how to ensure that at least they get the basic facilities in order to respond to the outbreaks, and of course the financial resources. So if you don't have financial resources in place, then you cannot provide them proper food on time, proper medication, vaccination, and so on. So from data to information, how do we ensure that the data that you are receiving, you are making a difference by producing information? And people, as a global community, they are aware of what is going on in such emergencies. Is it an emergency of public health concern at international level, or is it a emergency of just a national crisis? We produce situation reports every week. It depends on the nature of the outbreak and the grading. So if it's higher grade, for example, Zimbabwe, they announced a crisis, the national crisis, the last Zimbabwe cholera outbreak. It was not just an emergency, it was a national disaster. So that's how you create if the nature of the emergency. And then we decide, okay, this emergency, we need to produce proper reports so that people, the countries, the community, they are aware of it. And we produce infographics, we produce weekly bulletin, which covers almost all the ongoing outbreaks. And the major ones, our team in HIM, they write articles on the ongoing and the vital ones, the most prominent outbreaks. If you guys haven't subscribed it yet, I think you should do it. And then our team at DVA, they also produce EIS and DAWN. And these are actually the closed systems. They are not open. The WCO offices and some UN agencies, they have access to it because sometimes you cannot share internal information with everyone in the world. So you need to keep it little private, but yet you want to share this information with some people who can make decisions on that. And we then we collect all this data, we produce maps, we produce interactive dashboards, and of course scientific publications. So the program strategic position is, if you see that the data input elements are artificial intelligence and humanitarian information management, and then we take this input, the input level, and in order to produce data science and the maps and GIS, and to utilize it to produce information products and to do outbreak analytics. So in the outbreaks, it's very critical to make decisions on time, almost on the daily basis or bi-hourly, I think. So the challenges that we face in data and health emergency information management is very critical. Issues with consistency, accuracy, and integrity of data. Lack of database linkage systems. Most of them are using like Excel files. The most recent example I can give is about DRC. When I was deployed there, I received a few Excel files that was produced from different systems, was operational during the outbreak in Beni, in Itibu, North Kivu, and in different remote places. So when you use different systems individually, all these systems following different standards. When they are following different standards, they have different attributes, different data labels, and they are collecting data differently. For example, the vaccination data I received had different data set. They are collecting first name, last name, age, and gender without having information of the location. And the names sometimes are spelled incorrectly. It's not always the case that you will find that every individual is using the same spelling for the names. And if to link this data from other systems like VHF base, or they are using tracker there, to link all this data, you receive Excel file and they want, okay, how many contacts is produced from this particular index case. So it's very hard to know if you don't have proper linkage. So what I realized in my experience, the problem is not just about unique identifier. The problem is about the coordination of this identifier. The coordination mechanism was so poor so that we were unable to make the linkage between all these files, because there was no set of standards who will use which variable for which purpose. So I think there should be a minimum set of variables that we should collect for for the minimum set of information, regardless of unique identifier. I think if you have the information of age, gender, location, or province, you can easily make a unique identifier around this data set. So the other challenge is the centralized data system, which is, I already explained that each component of this application is working individually. And the lack of network infrastructure as well. The current ongoing emergency is in the area where you have very limited network coverage because there is a war going on there. So it's a very critical crisis. And you can just name it, what else is there. So there are too many challenges to get clean and qualitative data in order to make decisions. Sometimes it's very tricky. So what should we do then? Do we learn a lesson from this and we make sure that we do not repeat the same mistakes what we have done this time? So there are some pre-deployment consideration that HIM at WHE they propose to the partners, to the ministries, to first understand the country profile. It contains hazard profile, seasonal calendar, infrastructure, history, politics, and security. These are the key pillars that we need to focus on. Then conduct a rapid of immediate outbreak response needs. And the tool developed by HIM AFRO to do this. To development and implementation of an information management plan, which is highly critical. So when you have emergency, you don't have much time. You need to put IMS at place quickly. But this IMS should first focus on development and implementation of information plan. Who will provide us information on logistics? Who will provide us information on vaccines? Who will provide us information on contact tracing? Because all these areas are very critical. If you miss one contact, it means there is expectancy that this contact will fly to UAE and will infect someone in Dubai. So and then the monitoring of KPI. We need to see what percentages and alert investigated within 24 hours and context follow-up, context scenes. Mostly for Ebola, it's 21 days that you have to make follow-up on the context, up to 21 days. And after 21 days, if if you don't see any prominent symptom on the case, you can just discard it. So this is our guys deployed the EWARS kits in Ecuador in the 9th outbreak in DRC. So that's it for HIM. And now we'll discuss about digital health tools. What tools are available, the convergence of digital technologies to enhance the efficiency of healthcare delivery, and use of information and communication technology to help address the health system challenges during or emergency in active surveillance or passive surveillance, regardless of this. And digital health. So the digital health is a multidisciplinary domain which involves many stakeholders. So it's not just about the health professional or the techie people. It is taking all the community as a whole. The researchers, scientists, healthcare workers, engineers, social sciences, and public health, you name it, add more. So what is the importance of digital health? If we deploy a digital health tool during the crisis, what difference will make? Will we be able to make timely decisions? Will we be able to make sharing timely information? And this information, can we generate a rapid response from this information? And by rapid response, can you make effective decisions on this response, the ongoing one? And if yes, then how soon? Do you have concurrent access to qualitative data? And it's a key element. If you don't have concurrent and real-time access, then it means you will delay the information. For now, again, I will give you example of the recent ERC event. The context follow-up information is almost 24 to 100 days in between. We don't have this information, so we are working in a past. It should be concurrent. So the challenges, solutions, and approach that now HIM is taking on to address all this. There are 90 outbreaks in 2016 alone was going on in the critical ones in African region. And during all these outbreaks, the countries, different countries who are technologically advanced, they were using their own tools, which is fairly nice. But some countries who are under the process of developing these digital health tools, you have to assist them to deploy something. You cannot wait for 10 years, 5 years, 2 years, 3 years, so that they can build a digital health platform in order to manage the outbreak crisis. You have to respond it quick in limited resources as well. So in this case, you need timely information and you need complete data. Just sometimes the timely information is not enough. If you are producing timely information with incomplete data, you are producing the wrong information. You have to have complete data set, complete information to produce complete information in order to take proper decision. The solution that HIM is proposing is the Outbreak Toolkits platform. We are currently in process of developing simplified tools on Excel, on ODK platform, ONA, Kobo Collect, EWARS, and all these products we are placing it in one-stop shop, which is Outbreak Toolkits website. And the portal provides disease-specific outbreaks toolkits freely on the website, and which can be quickly adaptable in any circumstances to regardless of your administrative hierarchy. We had conducted a workshop in Dakar last year to invite countries to come and provide us requirements on if this tool is sufficient to address your needs. And we are creating a tool as flexible as we can to cover up all these countries. So what we have done is we divided countries into categories, we created groups, and for these groups we have developed a specific disease-specific tools in order to respond to the outbreaks. So the digital health tools available and widely in use today is of course ODK, and I am sure that you all are aware of it. Magpie, which is little costly. WHO has on a server, so if you are from WHO office, WCO, or you are from Ministry of Health, you can always request to WHO to provide you access on a server, and we are always available to assist on this. You have API Info, you have SORMAS, you have Kobo Collect. Activity Info is a great tool for evaluation and monitoring purposes. You have a tool from Dimavi, ComCare, and of course the DHIS2 tracker. Our team currently for contact tracing is using Survey 123 in DRC in order to respond to the current challenges. Of course, it's not the best solution, but still we have to do something in order to contain the outbreak. So it's fairly very easy to create the form in runtime. You can do it like in 5 to 10 minutes on different applications. So if you have created a form on ODK, the same form you can use on Kobo Collect. if you have created a form on Kobo Collect, the same form you can use on a server. So it's fairly easy to do this. It will not take much time. I hope that most of you who have IT background, they are already doing this. In ODK, what you can do is maybe you can collect GIS information, you can collect pictures of the events, you can have calendars, or you can create 2 or 3 forms together for contact tracing, outbreak form, alert notification forms, and the evaluation forms together in one package, and you can share it with the people so that when you receive the data, you can fairly connect it. EWARS, we have a mobile application for EWARS, and we will see in detail what EWARS covers in the next slide. So EWARS in a box is a project. It began in 2011 after having a global event to understand what measures should we take in order to quickly respond to the crisis. Where you have no network coverage, where you have complete disaster, no infrastructure, you just want to go and start reporting. So during the emergencies, the operational importance is existing national public health surveillance systems. You will find that maybe if you have crisis like this in a picture, maybe the government system, they are underperforming and disrupted or non-existent. They may quickly become overwhelmed. And I will give you example on overwhelmed systems. Like in DRC, what's going on is we are deploying many systems together, and the national capacity of the Ministry of Health to respond all these systems is very low. They don't have that much resources. They don't have these many people to respond to all this. So when one partner goes to the Ministry of Health and say, okay, I want to deploy this specific tool for contact tracing, and it has this functionality, that functionality, and the other goes to say, okay, I have this tool which works good in logistics environment, and I have that tool which works specifically for on no network coverage area. What we are actually doing, we are suppressing the capacity of the ministry. They are overburdened and they cannot handle it easily. So either we have to rethink how we would like to facilitate this work. We have to, as a community, we have to be together as a partners. We have to have one voice. If we have one voice, we will make a huge impact. So, to scale, okay, I have done with this. So one of the most immediate response is to establish an early warning system to detect and react rapidly to suspected disease outbreaks, and to collection of essential minimum data on selected diseases, and the timely rapid analysis of the trends is key to this activity. So it's addressing the same issue that I have just defined. That if you don't have minimum data set and each of these applications collects a different information, there will be no way to harmonize it in a better way. And you will always find that you will end up with data set like you are matching only few records and 10,000 of records. Okay. So the problem, we continue to rely on ad hoc systems, largely Excel-based systems to manage epidemiological data in emergencies, which is to the extent is okay. If you have nothing to do, you can rely on this because it's better to have something instead of nothing. But is it a right way? Can we do it better? Yes, we can do it better. No agreement on for now. All these organizations working together, they have no agreement on common standardized information tools that can be rapidly deployed to support disease early warnings and response whenever an emergency occurs. That's why we have multiple interventions, and tools that do exist are not comprehensive enough to do, and they do not have address the requirements in the field and lead to proliferation and fragmentation of data collection at the front line. This can lead to delay in detecting and responding to disease outbreaks, which can result in morbidity and mortality, which is like you will end up that you have many cases. Like for now, we have more than 450 cases in this current ongoing outbreak, and almost 300 people died. So the EWARS in a Box project is an initiative to strengthen early warning, alert, and response in emergencies, and it comes with tools, with the application, with by keeping in mind of the electricity challenges and the network challenges. It supports Ministry of Health partners through the provision of technical support, training, and field-based tools. So it's not just ministry or WHO specific. Any partner, if they want to initiate the same response to the crisis, they can avail EWARS in a Box and they can deploy it easily. This includes an online desktop and mobile application that can be rapidly configured within 48 hours of an emergency being declared. So what is the aim of all this? The aim is to reduce the number of cases and deaths that occur during emergencies. And through early detection of diseases, outbreaks, and the initiation of timely response alert efforts, you can minimize as much as possible. The early warning, alert, and response system is designed with the needs of frontline users in mind. We use technology and innovation to make disease control in emergencies easier and more effective by simplifying the tool itself and make it rapidly deployable and yet flexible. You can generate any forms quickly, and it will not affect any ongoing assignment that you have. And you can create sites. Each form could assist ministry to deploy on to address different challenges like contact tracing, alerts, vaccination, and so on. So the system is built to support specifically during emergencies. Some people confuse EWARS with the passive surveillance, and that is not the purpose of EWARS to run it in passive surveillance on a routine basis. What you need to do, you need to respond to the crisis, utilize this tool, respond to the crisis, and then ultimately close it down. To suppose, but some countries are still using for passive surveillance. And if suppose you have emergency and you are deployed somewhere in some country where you have ongoing emergency, how do you strengthen the surveillance during an emergency response to take proper measures? And how you will make sure that every individual who is responsible of decision making are getting alerts of this outbreak? And of course, to respond to the disease outbreak or to respond to a flood, humanitarian crisis, or a hazard, you can deploy it anywhere in any crisis as you want. So where EWARS is working currently, so this is, I think, from 2017. In Nigeria now they have built their own system, so I think they closed EWARS down. But on other areas, it's still operational. In Bangladesh, it was planned, and I think it's running now. In Ethiopia and Chad, it's ended. because of there is no more emergency now, as I said earlier, that you have to close it down when you don't have any such crisis. So how the structure is made of, what are the components involved in EWARS? We have a data hub, a mobile application, and the exchange. And the way it works, you have to, you will create an application, a form from your data hub, and it will be rapidly deployable on mobile application. So you can see how the data is flowing from the mobile network to the sub-national level and the national level, and then to the generating and triggering the immediate alerts to and sending it to all partners in data exchange, to the Ministry of Health and the relevant people who can make a difference and make decisions by utilizing this information. So, as I said earlier, in EWARS kit, there is almost everything you need to respond to the crisis. The kit comes with 60 mobile phones and with one laptop, which is a data hub, with the guides, how to make it operationalize, and with the power banks. So if you don't have electricity, you can still utilize and to continue reporting, and you can still utilize the components, the mobile phones on the sites of the events. So the configuration of the tool is fairly easy. It's not too difficult. You will find, I will share with you the link, the web link of the guide, where you can go and further explore how you can configure EWARS in real-world scenarios. We have a step-by-step guideline in this website, and it's totally self-explanatory. So you just need to just follow up the next steps, and you will be then able to deploy the tool in the field. So first you need to create an account of the user you want information from. Then you have to design the forms for what purpose you want to deploy this tool. You want to collect information on a specific disease, you want to create a specific disease form, or you want to do a survey, or you want to do a vaccination campaign. So mostly each country has certain specific form structure. For DRC, maybe it's in French, and it will be different. For Zambia, it will be in English. In Lesotho, it will be maybe in Soto, or it will address to all the language challenges. You can create form in different languages, and you have to then set up the locations where to create the hubs where you want to create to collect the information. So for example, if you are in Beni, which is in North Kivu, then you may create one hub in Beni and then in another in Mobalapo. So these two hubs can then communicate and exchange data via the data exchange protocol. Then you have to assign the roles and permissions to different levels of information. So for example, for Beni information, you don't want this to be shared with Mobalapo information because of the data privacy issues. Maybe some people have data sharing issues that I don't want to share data because I should first verify and then report it back to someone. I don't want this information goes straight ahead to my supervisor. I want to keep it private. So you can just configure these set of conditional rules in the tool. And of course, then once you're ready, you can always import your settings and you can import the data sets. So basically, if you see how the cycle is working, is first you're collecting the data from the point of information, then this point of information can be a facility or community based. Then this information is flowing to receive information in data hub, and sometimes the tool itself, it works offline. So if you don't have internet coverage or unreliable internet coverage, like sometimes you don't have internet, and if you just pass by the corner, some point you will find, oh, I have a signal of X, it is showing me X plus. The same thing happening with me here in the hotel. This is a nice example. So then whenever it's synced back with the data hub, you can then produce and publish the bulletins, situational reports for the management, and you can visualize the data on the dashboard. Each facility can have, each data hub can have their own dashboards, and you can have one major dashboard for all these data hubs as well. So on the alerts part, what if you report something and it is crossing the threshold? So some diseases, in many countries we have different threshold levels in IDSR. So for example, for VHF, I think from almost all the countries have, if you have one case of Ebola, then it triggers the threshold level, and you can set that threshold level in the application, and then you can rapidly notify to the users if it triggers, when you receive an information, if it triggers that threshold level, it sends email or SMS, whatever way you configured it, to the relevant people who should be getting this information on time. Then you have how to document and manage these alerts. For example, there is a possibility that I can detect a wrong VHF case. Maybe I'm too scared and I saw anyone has fever, and I just asked him random question, okay, do you have like the fever is 39.8, okay, so do you have like red eyes? So if the red eyes is because of the allergy, I can put it straight away to the VHF ward, which is because there is an ongoing outbreak, and I expect that, okay, yes, this should be an Ebola case. So I don't do much work. I just straight away put this person in isolation. So, and then when I realized that no, this case is just simple fever, and maybe this person has allergy in the eyes because of shower, and then I have to remove this alert from the log. So you have to maintain all this log in order to address to how best you can manage case investigation on the ground. And of course, you have to then involve rapid response teams. So there is a component in the EWARS that can be utilized by rapid response teams. Sometimes in disease passive disease surveillances, most of the time you have district surveillance officers who are part of rapid response teams. So they are the same guys who can manage data hub as well. So then integration with the laboratory surveillance. So if you are using MSF, for example, is in Equator outbreak, was responsible to manage lab information. So if you have one case and it got tested in MSF facility, and how do you make sure that this case is positive or negative? Because sometimes there is people are reluctant to share this information on time. So first we have to work around how best we can work as partners, and how do we integrate all these two systems together in order to have the real-time information system. So the EWARS is fairly flexible to connect with any other system, and to link the data sets with other systems in order to get timely information and of course accurate information. In outbreak response, we are basically collecting the case-based data in remote settings and then submitting, help facilitators submitting this information or community-based reports to the system. So it is almost the same, so I want to skip this slide. I already discussed about this. So this is the link I wanted to share with you. You can note it down maybe, or I will share it with you guys later. So this is how the portal looks like. So it has like fairly proper guidance on if you click on home button, then it will start guiding you for what purpose you are using it. Using EWARS as a basic and EWARS as an administration, they are two different components. So if you are a field staff, you should just click on the basic one, and if you are supposed to administer this tool, then you should always go how to configure. Mostly the people who do the configuration are the software developers or the people who are working in IT sector. So after you have data, there is a component of EWARS where you can have real-time maps producing from the information that you have. This is an example of Yemen, where you have the data set, and you can see they are using a totally different language, which is Arabic, not even English. So they are using English, but the most prominent is Arabic. And you can make it dual language. You can use the way you configure it, and then you can produce some data analysis charts and so on. So this is all about the good about EWARS. So how do we put it in place? How is it better for us to deploy in our country during the disease outbreaks, or what are the disadvantages? Because it seems like what I explained is there is all good in this product. So that's why we put in place advantages and disadvantages and limitation of EWARS. So I will not go to advantages part, but I will just highlight like what are the disadvantages of and limitation of this. So it requires further development regarding fully offline analysis and integration. For example, I said if you want to connect it with MSF, then you need to have one software developer who could assist you to connect and link this API with the system which MSF is using. And the second part is non-hierarchical data validation process. By data validation, I mean, if you receive a report as a supervisor, how easy it is for you to just right away validate this data and to record all this information. That is an element which is missing. And I hope that the concerned people, they are working on this to make it available, because it is not something which is too difficult to do in this system. Okay, that's it, I think. Thank you.